Alterations in Hormone Regulation, Part 1. We're going to be talking about the abnormals, but it's really important that you understand normal. So you need to know where the hormones are produced. You need to know what their target is. You need to know the results. So please review the normal chapter. All of that's in tables there. It will be a good review of what you learned in anatomy and physiology. This is the negative feedback loop of hormone production. The hypothalamus, which is up here in the brain, sends off regulatory hormones. They're called releasing factors that then go to the anterior pituitary. And then the anterior pituitary sends off what are called tropic hormones, but these are your stimulating factors. And then those stimulating factors go to the target organ. And then when it gets to the target organ, the hormone is released. When that hormone is released and circulates in the bloodstream, it gets back up to the brain. And the brain says, I don't need to send anything any longer. So it stops sending the releasing factors. So if it's not sending off the releasing factors, there's nothing that's going to stimulate the anterior pituitary to secrete those hormones. So it stops sending off stimulating factors, and therefore you have no hormones released from the target organs. And there's a figure on page 428 that's identical to the one that I just showed you. The hypothalamic pituitary system disorders, there can be a problem because the connection between the pituitary gland and the hypothalamus has been broken. That can occur because of trauma to the brain, cancer, a lesion of some sort, or surgery can cause that. Now, the antidiuretic hormone, ADH, you need to know what the initials stand for. So ADH is antidiuretic hormone. Not even reading anything else, you know it's against urinary output. So you're not going to have a lot of urine output if you have ADH being secreted. So antidiuretic hormone is made in the hypothalamus and stored in the posterior pituitary. Now, your ADH functions normally by saving water. It has no effect on sodium. Sodium kind of sneaks along with it sometimes, but it doesn't do anything to the sodium. It only saves the water. So ADH is secreted normally if your serum osmolarity is increased. In other words, if you have a patient who is dehydrated and their electrolytes look really high, and so they'll secrete ADH to save water, to dilute what's in the vascular system. If you're hypovolemic or hypotensive, the body says, we need fluid, we need to increase volume, and so it will secrete ADH. Now, you can administer ADH exogenously. It is the drug vasopressin. And when you increase that osmolarity, it can cause your sodium levels to drop and cause hyponatremia. So again, this is just looking at the reasons ADH is secreted. You've got a decrease in your blood volume or pressure. And so that the receptor sites in the atria of the heart or in the great vein say, not enough fluid, sends a message to the hypothalamus, goes to the posterior pituitary gland and says, get busy, release some ADH. That goes to the kidneys. I don't know, it skips ahead of me. And that increases vascular volume and decreases osmolarity. Keep in mind this box also of things that cause an increase in ADH secretion. Patients who have surgery oftentimes have an output that is decreased. Could be because of the anesthetic agents or the narcotics that they were getting. Fact of the surgery itself. So think about that and know why ADH is released. Because if it's not done appropriately, you'll get the syndrome of inappropriate ADH secretion. Antidiuretic hormone is secreted continuously in this situation that causes an increase in water absorption. As the extracellular fluid volume increases, the renin-angiotensin-aldosterone loop is suppressed. So the body doesn't save sodium any longer, because aldosterone saves sodium. So you're dumping sodium, but you're saving water, so you're increasing the volume of fluid in the vascular system, further diluting your electrolytes that are there, and so you're going to become very hyponatremic. This is oftentimes due to ectopic production of the hormone, oftentimes from a tumor cell. It most commonly is your small cell carcinomas of the lung. It could be due to brain injury or an infection. There's a table on page 450 you need to look at, and keep in mind that any surgery can increase ADH release for 5 to 7 days. So you're going to have transient inappropriate ADH. As I've said, it could be surgery, pituitary surgery or other surgery. You'll have production of antidiuretic hormone by infectious lung tissue. It could be a psychiatric disease. It could be drug reaction, and that drug reaction is the result, causes an increase in ADH release or potentiates the effect of the ADH that's already circulating. And those drugs are morphine, narcotic, nicotine, so guess what, folks, don't smoke, anesthetic agents, barbiturates, vincristine, which is an anti-neoplastic, I'm sure you remembered that, diuretic, or sulfonylureas, which are your drugs for diabetes. Symptoms are related to the degree of hyponatremia. So if your sodium level is 130, you're going to have thirst, impaired taste, anorexia, dyspnea on exertion. That isn't a deer that we're talking about. It's dyspnea on exertion, fatigue, an adult sensorium. They're not quite as awake and aware as they should be. If their sodium level drops to 120, they're going to have severe nausea, vomiting, and abdominal cramps. And if the sodium is less than 115, they'll be confused, lethargic, have muscle twitching. They can even have convulsions. They will have serum hypoosmolality, urine hyperosmolarity. Urine sodium excretion will equal their sodium intake. Water restriction usually results in an improvement in the hyponatremia. But remember, if your sodium level drops to less than 110, you can have irreversible neurological damage. Diabetes insipidus is when you have an insufficient or inadequate response to ADH, resulting in partial or total inability to concentrate the urine. So there are three types. You've got your neurogenic, which or it can also be called central, and this is due to an organic lesion, not cancer. Nephrogenic, that's due to end-stage organ failure of the kidney, because nephro is kidney, and that's because the kidney loses its ability to concentrate urine. Or psychogenic, and that's due to extremely high fluid intake that causes low antidiuretic hormone levels. These people may have up to 12 liters of urine out a day, 12 to 20 in your textbook. Now, the psychogenic diabetes insipidus is extremely rare. I have only ever taken care of one patient in my entire long career that had psychogenic diabetes insipidus. I worked the step-down unit, step-down coronary, and we had this patient who was drinking like 12 liters of fluid a day in and putting out 12 to 14 liters a day fluid out. We had him on a fluid restriction, but he was up and about, and he would go into the bathroom and get the water that he wanted. We did give him an IV to try and replace the fluid he was losing. And the doctor was trying to figure out what was causing this. And I went in to talk with the patient. And I talked to the patient like at 7:30 in the morning when I was doing my assessments. And I finally just decided to ask him, how come you keep drinking so much water? And he said, he told me to. I said, he told you to? He said, yes. I said, who told you to? Because at that moment in time, it was myself and the patient in the room. And he says, the man in the corner. So I turned and looked in the corner. There wasn't anybody in the corner. And I said, oh, how long has he been telling you to do this? Oh, he said, oh, probably a month or so. It just got so I couldn't manage too well at home on my own, so that's why I came into the emergency room. I said, that's okay. All right. So I finished my assessment, and I went out, and I called his primary physician, and I said, I know what's wrong with this man. He's on the wrong unit. He needs to be on the 6th floor, which is where we had our psychiatric unit at that time. And he said, why? And so I proceeded to tell him about the man in the corner. He said, you're right. Call the psychiatrist on call. So we did. He was evaluated, sent to the psychiatric unit, and did do much better, but it is very, very rare. His color was very, very, very pale also. So the symptoms of diabetes insipidus are low urine-specific gravity and low urine osmolality because it's not concentrated urine. You're going to have a high plasma osmolality because we're dumping all the fluid. So intravascularly, you're going to be a little bit dehydrated because you keep dumping this fluid. This is also going to stimulate the thirst center. So that's going to cause polydipsia, which is an increase in thirst, increased drinking. They're going to have a continuous thirst. Because of all the fluid they're drinking, they're going to have polyuria, or a lot of urine output. And they'll even have nocturia. In other words, they'll get up in the middle of the night and have to go to the bathroom. This can cause hydronephrosis, or water that's in the kidney. It can also cause an enlarged bladder. And if you do not replace this fluid that they're losing, they will become dehydrated. And this is looking at diabetes insipidus. ADH is vasopressin. So we're giving them vasopressin. DDAVP, vasopressin that is inhaled, oftentimes used for children who have enuresis or bedwetting. Hypopituitarism is due to decreased blood supply to the gland. The usual cause is a pituitary infarct or severe decrease in blood supply to the pituitary gland. It will cause tissue necrosis and edema. The symptoms are the result of the absence of the hormones that the pituitary gland produces. The major one is adrenal corticotropic hormone, ACTH. ACTH is necessary for life because it promotes the release of cortisol from the adrenal gland. So if you don't have ACTH, you don't have cortisol, you cannot respond to a stressor. So it does become life-threatening. Other possible causes might be tumor, head trauma, infection, surgery, or vascular malformation. Now, if you have too much from the pituitary gland, you get hyperpituitarism. This is due to a primary adenoma. It is usually benign, slow-growing. You'll have problems that result from metastasis or the tumor size. And think about where the pituitary gland is. That will cause severe headaches, fatigue, neck pain, seizures, visual field impairment because it's going to press on that optic chiasma where the optic nerve is located. And if it's malignant, it will invade the hypothalamus, the trigeminal nerve, and the ocular nerve. So you'll have some facial deformities as well as vision major problems. Acromegaly is hypersecretion of the growth hormone. This is the result of an adenoma, and it will cause giantism in children. In the adult, it causes enlargement of the bones in the face, the hands, the feet, the lower jaw, and the forehead. Symptoms are due to overgrowth of cartilage in the joints. They'll also develop enlarged tongue, overactive sebaceous, which are your sweat glands, and the ones that secrete the odor, sebaceous, the oil, and the odor, and the sweat glands. I was doing my peds rotation because if you ever talk to me in person, you'll know that peds is not my field. But during my nursing school, I spent 3 months at Children's Hospital in Columbus. And during that time, I took care of a 6-year-old who was 5'11" and still growing. And he thought it was fantastic because he could play basketball and football, and all of his other friends were too little for that. So he came in. He had a pituitary hypersecretion. He had a pituitary adenoma, and they went in and basically removed most of it, not all of it, because you still need ACTH. So he would have stopped growing about that time. If you like Stephen King, he wrote a book called Children of the Corn that was made into a miniseries with Betty Davis, if you remember her. That miniseries was back in, I think, the 70s or 80s. And he used the fact of acromegaly as part of his plot point in that book and in that movie. Old-time movies, Rondo Hatton was an actor who starred with Basil Rathbone and Nigel Bruce in the Sherlock Holmes movies, The Pearl of Death. And then you had the gentleman who starred in Jaws in the James Bond series. And then we had Lurch of the Addams Family that was on TV. They all had acromegaly. Symptoms are they have a barrel-chested appearance. They get backache because they have an increase in their joint cartilage that impinges on the spine. They get arthritis and joint pain and nerve entrapment in their feet, so that causes foot drop and atrophy. So walking becomes a major problem. They'll have interstitial edema. Their hair gets very, very coarse. Most of these people die because of hypertension, severe diabetes, or malignancy. Tends to occur more so in women between the ages, get the worst effects between 40 and 50. All endocrine disorders occur more in women. And if you have one endocrine disorder, you'll probably have another one. That's very enlightening. Dwarfism is the hyposecretion of the growth hormone in children. And there's a picture in your textbook that shows a normal 4-year-old, I think it is, and somebody who has dwarfism. I can't tell you what page that's on. But this is looking at acromegaly, how it's diagnosed, complications, elevated blood sugar, so they're going to get diabetes, going to have problems with that, and the symptoms that go along with it. This is from the memory book. And this is where we're going to start part 2. So this finishes part 1.